Well, welcome back, everybody. We'd better get going as we are time constrained. So we're going to continue with a discussion from the Adult Registry. As you'll know, Barts hosts the various registries that are supported and funded in part by the ITP Patient Association. We run the Pregnancy Registry and the secondary ITP, which is just up and running. We're not producing anything with the Pregnancy Registry this time because the data is being analysed. We aren't having a formal presentation from the Paediatric Registry because it's currently suspended, but hopefully by this time next year it'll be up and running again. John has put in a lot of hard work with Nikki for us to get it going, and that'll be under the auspices of the ITP administrative team who run the Adult Registry, so I hope we'll have something from that. But we'll kick off with Fred Chen, who's now the clinical lead for the Adult Registry. I just said, where's Fred? I couldn't see him, he's behind me. Who's going to now talk about the Adult Registry. Thank you.
Right, thank you. So I'm going to give you an update of the UK Adult ITP Registry, and I'll also give you a summary of the audit that we recently performed of the various ITP therapies over the last 25 years. So this registry was started by Professor Newland and Drew Proven about 20 years ago. And so far, as of April 2025, we have recruited 5,745 primary ITP patients onto our registry. Now, the registry collects cross-sectional data, in other words, data on patients at the time of diagnosis, as well as longitudinal data. In other words, we're able to collect follow-up data, so we're able to track the long-term development of a patient's disease and well-being. And the registry collects demographic data, clinical history, treatments, pathology results, and clinical events. We currently have 118 sites which recruit patients to our registry, which is hosted Barts and London. The study is governed by ethics, so we have ethics approval. All patients are consented for collection of data as well as blood samples, and the data is collected in a computer software called Rachael, and all the data is confidential. And although we have the names of all the patients, they're not entered onto the database. So this is called pseudo-anonymized. So we have a different kind of a code for each individual patient. So I think for many of you may want to ask, why do we have a registry? Well, I think the most important objective of registry is to improve the outcome of patients, to use the data from patients to improve the outcome for patients. It helps us to improve the understanding of a disease, which is very rare. I was surprised when talking to a GP during lunchtime that he has never seen a patient with ITP because it's such a rare disease. So for rare disease, it's really important to collect the data so we can make generic statements about the behavior, behavior of the disease, how they present, and so forth. And of course, with all this data, we're also able to improve the treatment and then support research, which again feeds back into the objective of improving the outcome of patients. So in terms of understanding the disease, we need to learn about the variation in clinical presentation to be able to identify different subtypes of ITP and, of course, track the natural history of the disease. In terms of improving treatment, the data will allow us to analyze the efficacy of drugs, of different drugs that patients have received. And this, in turn, will also inform the development of guidelines for managing the disease. And it supports research, it informs how you design clinical trials. And it can also help basic research, especially using a combination of our data and the genetic data provided with the blood samples. So I also want you to know that this registry belongs to several stakeholders. Of course, foremost are the patients and the family, or the ITP patients. The UK ITP Support Association, patient advocacy groups, of course, are closely associated with the registry. And of course, clinicians, ITP specialists, rely on a lot of the data we provide to guide them to manage patients. Of course, research scientists to develop the field of ITP research. The pharma industry needs data from the registry for their drug development and developing their clinical trials. And of course, the regulatory bodies. I mean, for example, we have provided data to NICE during the health technology assessment for NICE approval. So going back to the registry, we have so far recruited, or this one shows you the recruitment over the past 10 to 15 years. And you can see that over the past 10 years, we've had very stable recruitment of between 300 to 500 patients. And the last number, 171, is how many patients we've recruited this year alone, 2025. So the registry consists of 3 arms. The largest arm is the primary ITP cohort. And here we have over 5,000 patients. But the last 2 to 3 years, we've also started an arm for pregnancy in ITP patients and secondary ITP. And this is really important. I mean, in pregnancy, for example, ITP per se is very rare. And to have somebody with ITP undergoing pregnancy is even more rare and very difficult to manage in a sort of general hospital. And we don't have much data about ITP patients, who are pregnant. There are questions like, what's best with managing these patients? How do we use TPO? Is TPO safe in pregnancy? So these are all data that needs to be analyzed. And we now have more than 100. So the data is now ripe for analysis. And then for secondary ITP, this is another arm that we established about a year ago, actually 2 years ago, and now we've also reached this magic number of 100 patients. And you can see that 20% of ITP patients are associated with other conditions, and I think this particular slide has been shown by several other speakers. And and we don't really understand the interaction between these secondary diseases and ITP. The treatments are different. So again, I think we would learn a lot by collecting data with this secondary ITP. And these are a list. This is a list of all the participating centers, all the centers that recruit patients to the ITP registry, and I really like to thank all the hospitals and all the PIs and nurses involved in recruiting patients. Now I'd like to present to you an audit we performed to look at the treatment the patient have had over the past 30 or 40 years actually. And the aim of the audit is to see how treatment has changed over the last quarter century in the UK, and whether the recommendations of the latest international consensus guidelines for ITP, which was published in December of 2019, have been implemented. And also to assess whether these changes have actually made any difference to patient outcome, which is what you want to know, I think. So, again, I think this slide has been shown several times before, but I'll just go through this briefly again. Although ITP is a really rare disease, it's been known for more than 1,000 years. So the first case of ITP, as far as we know, was described in the Canon of Medicine by Ibn Sina from Baghdad in 1025. And if you're interested in this history, there's a beautiful paper written by Professor Newland on the history of ITP. And then ITP was described again 700 years later by Verhoef, who described, I think, 2 or 3 acute cases of 2 girls or 3 girls who had acute ITP. And for another 200 years, nothing happened until 1916, when Tasnelson, a Austro-Hungarian physician, performed a splenectomy to cure or to treat ITP. So this is the first treatment for ITP. And then, oh, by the way, Tasnelson actually worked in Liverpool during the Second World War, just around the corner from here. And then in the 1950s came the corticosteroids, cortisone, and in the 1980s we witnessed the first use of intravenous immunoglobulins for children with ITP. And it wasn't then until 2001, when rituximab was used for the first time in patients with ITP. And since then, we had a whole series of novel agents coming onto the market. And in the UK, which is slightly different from the US or other countries, we saw the introduction of romiplostim in 2011 when it was approved by NICE. And then soon after, eltrombopag in 2013. And in 2022, we had avatrombopag and fostamatinib. The new guidelines came in December of 2019. So this is a summary of the guidelines, and you can see that at the top you have the guidelines for management of, first management of acute ITP, which hasn't changed since, I guess, the 1950s or 1960s, which is really based on steroids and then IVIG. And the changes have really come into the second-line treatment. So you can see the middle box there, which gives you a number of drugs which have very good evidence base. So these are drugs that have undergone clinical trials, and these are the drugs which are recommended by the guidelines to be used as second line. Okay, so in the UK, it's mainly TPO and rituximab, and increasingly we kind of use TPO as second line treatment more than rituximab. And then splenectomy, the traditional treatment, has been relegated to the sort of last resort option. And fostamatinib in the UK is only used after TPO for patients who are refractory or intolerant to TPO. Okay, so we took the 5,000 patients and we split them into 4 groups, P1, P2, P3, P4. So these are 4 different time periods, and each time period is defined by the introduction of a new drug or guidelines. So, for example, the P2 from 2001 to 2010 is a group of patients which were defined by the introduction of rituximab, and P1 will be patients before these novel therapies. P3 are patients who were defined by the introduction of the TPO receptor agonist, and then P4 are the patients defined by the time when the new guidelines were introduced in 2019. So these are the 4 groups of patients, and we'll then analyze these groups independently or separately, and these are the results. So you can see these 4 pie charts, which represent the drugs used, the second-line drug used in these different time periods. So to the left, you had the drugs or the therapies used before the year 2000 from the last century. And you can see that like 70% of patients underwent a splenectomy. And, but from 2001 onwards, in other words, since the introduction of rituximab, you can see that the number of patients undergoing splenectomy had already decreased. Around the same time as rituximab, we also started using mycophenolate for autoimmune cytopenias. So that use, the use of mycophenolate also started to expand. So by 2011, when TPO came in, mycophenolate was still used, considerably, as well as rituximab. These are counted, rituximab and MMF count for more, just slightly over 50%, but now there's a strong representation by the TPO agonists. From 2020 to present, the scene had completely changed. Yes, it was in part since the introduction of new guidelines, but it also coincided with the COVID pandemic. So you can see that in the last 5 years, the majority of patients are now started on TPO agonist as second-line treatment. And in fact, if you look at the data before and after the international guidelines and COVID, you can see that the use of TPO had increased from 26% to 76%, whereas the immunosuppressive drugs of rituximab and mycophenolate had come down from 28 or 24% down to 9%. And just wonder whether we are underutilizing these drugs, rituximab and mycophenolate. And you wonder where should we be positioning rituximab? Now, the big question is, after so many new drugs and after so many billions of dollars being spent on developing and purchasing these drugs, have they made any difference? And a registry is a good way of providing a kind of a bird's eye view on the effect of the change in practice. So we looked at some outcome measures to see whether we can demonstrate any improvement in treatment. So we looked at how many lines of treatment patients required, so back in 2000 compared to now. Have patients less bleeding as a result of a change in practice? Ultimately, the main problem with ITP is bleeding. Has there been a change of thrombosis? Has there been more thrombosis because of the use of TPO? And what's happened, has there been less or more infections? Because ultimately, a lot of these immunosuppressive drugs make patients susceptible to infections. Well, first of all, we looked at whether first-line treatment has changed over the years. And in fact, so each bar represents a time period, and you can see that the number of patients receiving first-line treatments with steroids and IVIG hasn't changed at all over the last 25 years. 80% of ITP patients receive steroids and intravenous immunoglobulins. Nothing has changed. Either this is perfect treatment or there's some unmet need here. This is looking at how many lines of treatment have had during the different time periods. So if we go back to the first time period, the mean number of lines of treatment the patients required was 2.5. In the last 5 years, since 2020, the mean number of lines of treatment patient required is 1.5. So there has been a reduction in the number of treatments the patient required. This one looks at the proportion of patients who require second and subsequent lines of treatment. And if you look at second-line treatment in the top left bar chart, you see there's a slight reduction in requirement for second-line treatment. But actually, in the last two periods, P3 and P4, there's not much difference, really. So the number of patients requiring second-line treatment has probably remained the same. But if you look at third-line treatment, you can see there's been a decrease in patients requiring third-line treatment. And the same pattern is seen for fourth-line and fifth-line treatment, suggesting that maybe second-line treatment has improved, so there's less relapse and less refractoriness. So the other outcome measure is bleeding. We looked at just all the bleeding events, and we couldn't really see much difference between the time periods. But if we look at critical bleeding, then we see there is a difference, and there seems to be a decrease in critical bleeding. Critical bleeding here is defined by intracranial bleeds, pulmonary hemorrhages, gastrointestinal bleeds, ocular bleeds, and gynecological bleeds. So there seems to be some improvement. Current treatment seems to have contributed to less bleeding, less critical bleeding. This is showing a longitudinal picture of bleeding events over a period of 2 years from diagnosis to 24 months from diagnosis. And it's quite interesting. So the blue line, so the one at the bottom, represents the last 5 years, So this is a TPO era where 76% of patients receive TPO as a second-line treatment. So you can see that the bleeding rate, so these are different periods, So we're looking at the number of bleeding events in the first month of diagnosis, month 1 to 6 months, and 6 months, 12 months, 12 months, 24 months. So you can see most of the bleeding happen in the first 6 months. And if you look at the blue line, so the TPO era, incidence of bleeding actually decreases after 6 months. And of course, 6 months is a time point when we actually start using TPO in most regions of the UK. So this is really to show that maybe the unmet need is still in the first 6 months of diagnosis. And then this is issue about thrombosis. So according to our data, the frequency of thrombosis decreases over the past sort of 3 time periods. So it seems that with the advent of TPO, the frequency of thrombosis has not increased. Yeah. So this is our data. I understand that in the trials where the data is very granular, there has been kind of a 6 to 8% incidence of thrombosis, but we can't see it from a bird's eye view using the registry. And 4, is there a difference in a change in the frequency of infection? So we haven't seen any change in infection frequency through these 4 time periods. So in summary, there has been significant changes in treatment pattern since the new guidelines in 2020, which is probably or most likely accelerated by the COVID pandemic. So there's an increased use of TPO from 26 to 76%, and concurrently a reduction in the use of immunosuppressants, mainly rituximab, down to 9%, and mycophenolate also down to 9%. And importantly, we know that the current practice is in keeping with the recommendations of the 2019 guidelines. So you can say that the guidelines have been extremely successful and fully implemented in the UK with the help of COVID. And there is evidence, importantly, there is evidence of improved overall outcome. There's less use of subsequent lines of therapy, which reflects improved second-line therapy. So again, this is a plus point for the use of TPO. There's a decrease in critical bleeding, a decrease in thrombosis against expectation, but no change in the frequency of infections. And I would like to take this opportunity to thank all the stakeholders, so the patients, in particular the ITP Support Association, which directly supports this registry, Barts Charity, the NIHR, which is really important. It's one of the few countries that has a national network of individuals or organizations that support research embedded in every trust. Yeah, they help to recruit patients. I'd like to thank all the PIs and colleagues. I'd like to thank Harun Mia, who's our senior data analyst, and Atika Mia, one of our data manager. And finally, I would like to acknowledge the help of industry and institutions who have supported this project. Thank you.
Thank you, Fred. That's a fascinating snapshot, and I think shows the value of a registry that's maintained over such a long period with some really important breaking data there. If there are any immediate questions, Drew.
In terms of the infections, which haven't dropped, from the 2001 paper from Portelli and co, they said that there are many deaths caused by the immunosuppression, and that was a big deal, but yet we've seen no reduction even though using fewer immunosuppressants. Any explanation for that?
No. I mean, again, the data is a kind of a bird's eye view, isn't it? It's supposed to be really granular data from clinical trials. So I think the overall picture, the message is that infection is not a major issue.
Could you talk into the...
Oh, sorry. Yeah, so I think the take-home message from the registry data is that infection doesn't seem to be a major issue.
That woke us all up. So, Fred, a quick question, if you can fix the microphone. First of all, in terms of the no change in corticosteroids, do you have an ability to capture how long patients are on corticosteroids? Was the duration of corticosteroids less in more recent years than in former years?
I'm sure we can look at that,
Okay.
but we haven't.
Okay. And the second question, I'm a little bit concerned about presenting data like thrombotic events as a percentage of the patients. I think it's better to present the number of events per 100 patient years, and I think that's a better way to present this data. It'll give you more granularity as to how do you compare time periods where the time periods differ.
Yeah. Thank you.
You'll have to stand in the box, Rachel. Any further questions? Otherwise, we'll go on to the next presentation. Now, as I said, we aren't having a presentation from the pediatric this time, but Rachael, who comes from Boston Children's Hospital, is going to primarily talk about secondary ITP and inherited platelet disorders from a standpoint of pediatrics, but it's also relevant to actually everyone in this room. So I'd like to thank Rachael for coming over from the States and to give her presentation. And I hope the microphone is for that.
Good afternoon, everyone. I'm Rachael Grace. I'm a pediatric hematologist at Boston Children's Hospital, which is in the U.S., and I'm so pleased to be here on the 30th anniversary of the association and have enjoyed this meeting so far and being with all of you. I'm going to be talking about secondary ITP and inherited platelet disorders, and I'm going to try to avoid the alphabet soup of medical terms and immune hematology in particular of ITP and then IPD, which is inherited platelet disorders, and PID, which is primary immunodeficiencies. There are a lot of abbreviations in immune hematology, and I will try to avoid them or show you where they are as much as I can. As part of my general practice in patients that I'm seeing, I'm often asked in new patients how I can be sure that this person has ITP. And when I see patients in second opinion, which I do a fair amount, I'm again always asked, are we sure that this is ITP? And as has been mentioned multiple times already today, it's with some frustration that ITP is a diagnosis of exclusion. And what do we mean by that, as has been talked about already today? It's really based on a history of somebody generally who has been otherwise well up until this point recently, where bruising and maybe petechiae have been noticed, perhaps in the setting of some mucosal bleeding as well. And when we examine that person, typically we don't find other things besides having those skin-based symptoms or the mucosal bleeding symptoms, but we're not seeing other findings on the physical exam that make us think about another reason for the low platelet count. The lab findings include an isolated low platelet count. That means typically the white blood cell count is normal, the red cell count is normal, and it's important for hematologists to review the peripheral blood film, the slide of the blood cells that's made when those blood counts are done, and that's what's shown underneath this child down below, where you can see healthy red blood cells where they look like red circles. You see a healthy white blood cell, that's called a lymphocyte, that's the big blue cell, and then up in the corner is a smaller blue cell, and that's a platelet. And what we're seeing is that the platelet, you're going to have to just believe me that this is a large platelet, which is what we would typically see in somebody who has ITP without other findings of the other blood cells. And then there's the important consideration and an exclusion of other causes of a low platelet count. And that's what we're going to be talking about during this time. And what are those tests that need to be done initially? Sometimes those are tests about looking at infections. Sometimes those are driven by the history and the exam and specific factors to that person and their age potentially as well. Sometimes we think about, too, what's the response that person's had to their ITP-specific therapy? So that's been mentioned earlier. Did you get steroids and did you have a platelet response even briefly? Did you get intravenous immunoglobulin and respond even briefly? And then, of course, ITP can be primary or secondary. So even at that initial visit, as practitioners, we should be thinking, is this primary ITP, or should we be thinking that this is a secondary process? So I'm going to talk about a few individuals, and maybe you could find yourself similar to these individuals regardless of their age. But this is a 14-year-old young teenager who has been healthy to date, and she's had 2 days of bruising and petechiae, and she's had a month, though, of progressive fatigue and hair loss. She also has morning stiffness when she's waking up in the morning in her hands and her hips, and that seems to get better as she starts to move around. And she tells us too in the clinic that she's had left knee pain most days and some swelling, but she's been really busy with lacrosse, and that seems to be worse after she plays and gets better after she ices it, and so she thinks it's probably just part of her sports injury. And when she's examined, she has the bruising and petechiae, and her knee exam shows some swelling, but it's also feeling warm too. She has complete blood counts, the white blood cell count and the red cell count are normal, and she has that isolated low platelet count like I was mentioning. So what are the clues here that would make me, as her hematologist, think maybe this isn't primary ITP? These are the hair loss, right? This isn't an otherwise healthy teenager. Why is she having hair loss? She has morning stiffness in her joints that get better during the day. She's having this knee pain that on exam is an abnormal knee that looks like arthritis. And she's a teenager, which always makes me pause just by age alone. Is this really primary ITP? And so what do we mean, because it keeps getting mentioned today, by primary and secondary ITP? There are lots of different ways to break this up, which is what Dr. Newland was talking about earlier. When we say primary ITP, we mean it's ITP that doesn't seem to be associated with any other factors or medical conditions, where we don't have anything to kind of point our fingers at to say this is ITP associated with this other problem. There's also ITP that seems to be associated with other autoimmune problems. Somebody who has type 1 diabetes, immune thyroid disease, they have multiple sclerosis. Immune problems that don't seem to get better when you treat those other autoimmune problems, but somebody who has multiple autoimmune problems, where in a young person, or really from my perspective, anybody at any age, would make you question, why does this person have multiple autoimmune problems? There's ITP that's associated with primary immune dysregulatory disorders, or primary immunodeficiencies, or inborn errors of immunity. Those terms kind of all mean the same thing. Something fundamentally going on with the immune system that we can point our fingers at and say, this is an immune defect caused by a specific genetic problem, or has associated immune testing where we would say there's an immunodeficiency here. And then there are processes where we would say this is a secondary ITP, where if we address the issue that the ITP is secondary to, that's going to help treat the ITP too. So those are chronic infections like HIV or the hepatitis viruses, in some areas of the world, H. pylori. There are rheumatologic diagnoses like the patient we were just talking about who seems to have a rheumatologic problem, potentially something like lupus. There are people who have antiphospholipid antibodies. These are antibodies in addition to platelet antibody, or platelet antibodies that make somebody more prone to developing blood clots. There are people who have underlying cancers that ITP can be associated with. There are certain medications people take where they develop platelet antibodies, and when you stop the medication, the ITP resolves. ITP can happen after certain cancer-directed therapies that put your body more at risk for developing ITP, and then ITP can occur after you have a transplant, like a bone marrow transplant or a solid organ transplant, like a kidney or a heart transplant. So there are lots of forms of secondary ITP, but also lots of forms of primary ITP with other autoimmunity. And I have these circles here because I think of all these as being relatively overlapping, so that if somebody has, as I mentioned, type 1 diabetes and ITP, that makes me think, do they have a primary immune problem that put them at risk for these issues, and do they actually have an ITP associated with an inborn error of immunity and not only with the autoimmune phenotype? People who have Evans syndrome have more than one immune blood cell count, so they have ITP potentially, or a red cell problem that's called autoimmune hemolytic anemia, or a white blood cell problem that's called immune neutropenia, so some combination of 2 of the 3 or 3 of the 3. And those individuals also seem to have a question around an underlying immune disorder. And when we think about people who have primary immunodeficiencies, a lot of people think, well, that must be associated with getting more infections. And I don't have a lot of infections, so I don't think I have a primary immunodeficiency. But people who have primary immunodeficiencies are prone to autoimmunity. That immune dysregulation is something that sets you up for autoimmune disease, not necessarily infections. And so ITP can be a first sign of having an underlying immunodeficiency. And 30% of patients who have immunodeficiency have cytopenias, and the risk of ITP in that group of people with immune deficiencies is 400 times higher than the general population. And ITP is a common presenting symptom. So this is something we think about all the time in children who present with ITP and thinking, is this the first sign of having an underlying immune problem? And there's increasing evidence for sure in children who have ITP and also Evans syndrome, the multiple autoimmune problem, that we should be thinking more about these immune problems, and that depending on how patients are referred for more testing, there seems to be somewhere between a 5 to 20% rate of an underlying immune defect in the individuals with ITP, and even higher in people who have Evans syndrome, more like 40 to 60% of children. There are more studies now recently in adults having this kind of testing in both ITP and Evans syndrome, and it seems to be potentially lower than it is in children, this rate of finding an underlying immune defect, but still a significant number where it needs to be strongly considered. In terms of thinking about immune cytopenias and people who have immunodeficiency and why it's important, people who have immunodeficiencies may need different management. So one important part of this is thinking about their treatment. So it was mentioned earlier that we don't really have targeted treatment. We understand how the drugs work that we have and where they target the immune system, but we don't really understand what is wrong with the immune system, specifically in an individual with ITP. But for people who have a single gene problem, where we know what's wrong with the immune system, we do have targeted therapies for some of those issues, and they would address the ITP in those patients. And they're not the same list of treatments that we've been talking about all day. So if you look what's highlighted in the yellow on the side of your screen, you'll see those are not the drugs we've been talking about. So medicines like sirolimus, something called a JAK inhibitor, which there are several, including ruxolitinib, abatacept, hydroxychloroquine, medicines we haven't mentioned today. So this is one of the reasons why it's important to know if you have an underlying immune issue, to know if one of these medications actually may be more effective for your ITP. There are also other supportive treatments sometimes people need. We realize actually that person doesn't make antibodies very well and needs to have supplemental antibody infusions to help boost the immune system. There's also other autoimmunity that people are at risk for, so not just ITP. We get very focused on the blood counts because they're so easy to measure, but then we miss that somebody has an immune problem with their lungs or an immune problem in their gastrointestinal tract. And so it's important to identify if there's an underlying issue to know what we should be monitoring for. And then also, it's important that our treatment addresses those other issues. So we may be so busy looking at the blood counts that we don't monitor these other issues which have active immune problems because of this immune issue. And then there's bigger treatment sometimes needed depending on what the underlying immune issue is, including stem cell transplant, which we don't talk about in ITP. So what are some clues to an underlying immune disorder? So one I already mentioned is having more than one immune blood cell count, either over your lifetime or at the same time. Having additional autoimmunity, so having multiple autoimmune problems, as I mentioned. Having family members who have multiple family members with autoimmune problems, or family members who've developed lymphoma or leukemia. As Dr. Cooter was mentioning earlier, in these long-term outcome studies of adults with ITP, there seems to be a risk potentially of hematologic malignancies. Those are leukemias and lymphomas, and we know that people who have underlying immunodeficiencies are at risk for those disorders, and so maybe that's a kind of a representative of the subpopulation who has ITP, who's at risk for these kinds of disorders because they have an immune defect. People who have an abnormal exam, the lymph nodes are big, or have had a big lymph node that got excised in the past in a surgery to see what was going on, or people who have an enlarged spleen or enlarged liver, which is not typical for ITP. Maybe they've had a poor response to prior therapies. That makes you think maybe they need a different thought about their immune system in terms of what therapy might work, or having an atypical course. So that can be defined in a lot of different ways, but I would say in my practice sometimes too, that's a child who has multiple other medical problems that seems to fit more into a syndrome or a genetic issue than it does with a primary ITP. So how do we test for immunodeficiencies? It's with blood work. So we look at immune testing, functional immune testing. I list here some of those types of tests. They fall into a few categories. So one's looking at the kinds of white blood cells people make called lymphocytes, how well they make antibodies, how well they respond to vaccines, and whether they have markers of inflammation that are ongoing. And then we look at genetic testing too. There are now over 600 genes described that are used in these immunodeficiency panels, many of which lead to this immune dysregulation, leading to autoimmunity. And when we think about testing people for immunodeficiencies, it's important to do this in the context of having a practitioner who can help interpret the results. So many people can send these tests, but you need to be able to understand what the results are when they come back. So working on this with your hematologist, if they're able to review the results, if you're someone who should have this type of testing, or immunologist or rheumatologist, whoever has expertise in your area, in the area that you live in. So what about other kinds of secondary ITP? I really focused on primary immunodeficiencies or inborn errors of immunity, but what about ITP with autoimmune phenotype? How do we think about individuals who could be at risk for that? Some populations are more risk for secondary ITP with systemic autoimmunity. In my pediatric practice, that's more adolescents than it is young children. People who have a strong family history of autoimmunity. We often send screening antibody testing, including an anti-nuclear antibody testing, in people we think may be at risk for this, including based on just age alone, or those antiphospholipid antibody tests at the time of diagnosis in particular, and then sending a more expanded panel where there's more concern based on the exam, like that young lady that we were just talking about. So how do we do that? This is with other blood tests, and some of them are listed here. Not all of these tests need to be done in everybody. So that's true of those immune panel testing. This is true of these autoimmune tests. But in people who have potentially certain findings on their history or their exam or their family history, I wanted to highlight that in a recent study that from a group in France, 20% of children who had an immune cytopenia at the time of their first diagnosis had a positive anti-nuclear antibody test. That's a general test for autoimmunity. And over 20% of those children developed lupus over a span of time of 5 to 10 years or even longer. None of those who had a negative ANA test at the time that they were diagnosed developed lupus. And in that same group, when kids who had that positive ANA test were started on a medication called hydroxychloroquine, fewer of them developed lupus over time. So that's why these tests are important to think about, because they really do change our practice and they really do change what happens with people. And we need to understand this better, but identifying the right people to have this kind of testing is an important start. This has been shown many times today. I actually think this is the 4th time that the graph on the purple graph has been shown. To just think about how often is ITP associated with another immune diagnosis. And I think actually the juxtaposition of these two pie graphs is interesting. So the yellow one is a pediatric cohort based on real data. So this is a single center from Dr. Michelle Lambert, who works at the Children's Hospital of Philadelphia. And you can see that that more than half of that group was identified as having not primary ITP. So this goes back to this question: do people really have primary ITP? And actually, the pie graph that keeps being shown is based on adult hematologist expert opinion. So that may not be right, and it may be that that needs some updating based on actual patient data. So let's move on to considering this next young adult. So this is now a 28-year-old female who's had easy bruising for as long as she can remember, her whole life. She has had chronic nosebleeds. After a severe and very long nosebleed when she was 9, she went to the ER and was found to have a platelet count of 70. She saw a hematologist and was diagnosed with ITP. When she started to get her menses, she had very heavy menstrual periods, which have been ongoing for her. And her platelet count continues now into the 40 to 70 range, and she has an elevated, what's called an immature platelet fraction. So her very youngest platelet count, the platelets that are circulating, is very elevated. So when we saw this patient in clinic, we reviewed her peripheral blood film, and you can see a comparison on the top and the bottom. So the bottom is hers, where she has these purple cells are her platelets, very large platelets. They're just as big as her red cells. We would say those are giant platelets. And the figure on the top is a patient with ITP who has that similar platelet count, a platelet count around 70, and you can see how much smaller that person's platelets are than this patient. So what are some clues about this patient that makes you think about an inherited platelet disorder, which is not ITP? So this person's had lifelong bruising, always had bruising and bleeding. This person has a platelet count that's higher than you'd think it would be with the kind of bleeding that they've had. The platelet count was 70 and they were in the emergency room with a nosebleed. They have this very high immature platelet fraction, so their very youngest platelets are even higher than we see typically in people with ITP. And then there's this kind of uniformity of how big the platelets are when we look at the slide, which really shows how important looking at that slide is in our hematology practice. So what are some clues about an inherited platelet disorder? So these are genetically caused low platelet issues. These are not ITP. These are lifelong congenital. You're born with kind of low platelet count problems. So we think about this when there's a family member who has a low platelet count. So when I see a young patient and they're with their parents and the mom says, well, I have ITP too, and so does my mother. Well, that's just a clue that this is not ITP. It shouldn't be that it runs in the family. That makes you think it's a genetic low platelet count issue. Or that there's no prior normal platelet count. Some people have never had blood count done before and we don't have a prior normal platelet count. But if there's been a platelet count 3 years ago and it was also 70, that would make you think maybe this really is an ITP and it's a genetic issue. This lifelong symptoms, the moderately low platelet count, it's never been a platelet count of 5, it's never been 15, it's always sort of been 40 to 70. Poor response to ITP treatments that have an immune mechanism, no response to steroids, no response to IVIG, and so on. These inherited platelet disorders respond to thrombopoietin receptor agonists. So it's always a little tricky because maybe somebody didn't respond to therapy until they got L-Trombopag for the first time. That should still make you think about a genetic low platelet count issue from a hematology perspective. That there's significant symptoms despite having a moderately low platelet count. That's because there can be platelet dysfunction. The platelets don't work as well in some of the genetic low platelet count issues. And so sometimes we see bleeding at higher platelet counts. That the blood cells under the microscope look atypical, or that, again, there's a sort of very high, very young platelet group that we're seeing. How do you test for these inherited platelet disorders? It's through blood testing again. Generally, we check through an inherited thrombocytopenia gene panel, it's called, and there's over 30 genes described currently. And these panels always get updated with more genes as more are discovered over time. There are other platelet tests that can be done that are more specialized but difficult to do, and so not available broadly. So I wanted to end with saying, why does this matter? I've tried to highlight a little bit, why does it matter? But just trying to think through each of these, primary ITP, secondary ITP, and inherited platelet disorders. So the prognosis, primary ITP, at least in children, is more likely to admit, in adults sometimes too. Secondary ITP is more likely to be chronic, and inherited platelet disorders is a genetic lifelong issue. It doesn't remit. Associated medical issues, primary, as I said, that's by definition, there aren't any. Secondary, there are always other issues. And inherited platelet disorders, it's variable. Some, it's just a genetic low platelet count issue and not any other issues, but sometimes they can be associated with kidney issues or hearing issues or a risk of developing bone marrow cancers that needs close monitoring. So it's really important to identify these so that people are monitored appropriately. The bleeding risk can be different, so it's variable in ITP, as we all know. In inherited platelet disorders, it can be variable too, where there's not a lot of bleeding in some, and because there can be platelet function issues, there can be extensive bleeding in others. The monitoring can be quite different between the two. So I mentioned already, if there's a primary immunodeficiency, there might be a lot of monitoring that's needed that's outside of the hematologic realm, whereas in inherited platelet disorders, it depends on the type, as I mentioned, and whether there's a risk for cancer or there's more bleeding over time. And then the treatment approaches are much different. ITP is an immune disorder, so you're getting at platelet destruction in addition to production, where the destruction is with immune modulation or splenectomy, as we've heard about. For inherited platelet disorders, splenectomy is not going to work, immunosuppression is not going to work, and so those are medicines with significant toxicity that you wouldn't want to give to somebody that shouldn't have them. And then thinking about other family members. So in ITP, we tend to think of that, as I mentioned, something that doesn't run in families, but inherited platelet disorders do. And so it's important for people who have a family member who has a low platelet issue to think about whether they might have a genetic issue and not an immune issue. So to summarize, primary ITP is a diagnosis of exclusion, and other causes for a low platelet count need continuous consideration, not just a diagnosis, but over time, regularly, in everybody who continues to have chronic ITP. You need regular consideration about your prior testing and the need for additional testing. ITP is a common finding in people who have immunodeficiencies, and as I mentioned, the management differs. Inherited platelet disorders the same, that management really differs in terms of both monitoring and treatments. And it's important for everybody who has ITP to consider reviewing your prior testing with your hematologist and consider whether there's further testing that should be done with your next visit. And with that, I thank you for your attention.
Thank you, Rachel. We could probably have time for one or two questions, otherwise we can explore it in the Q&A. Ella? We have a microphone somewhere.
Thank you. That was a really, really informative talk. I really enjoyed that. My question was around sort of patients, on behalf of patients. How do we address with our care providers where there is maybe a lack of knowledge or a lack of resource or even a lack of curiosity to find out about, primary and secondary ITP, and then as patients, what are tests that we could maybe ask for? How do we even have those conversations? Because I know anecdotally for myself, it's only really, consultants in the room, only really recently with him that I've had these conversations and that we've spoken about why has this happened, why have you got ITP, and I find it really interesting, so thank you.
I think it's especially a hard question, I think, for me to answer coming from a different medical system than you have here. But I think having an alignment with your provider and feeling like you can talk with them about different questions you have. I do think you could come from this meeting saying that I came to the ITP Support Association meeting, this was discussed, can we review my testing so I understand what other tests maybe we should think about together. I don't know exactly how it works here in the States. Somebody can ask for a second opinion to see somebody who has a more specialized focus in ITP or in immunologic issues, and it could be that your hematologist is happy to have that person's input in thinking about what other tests can be done. And I know that there are gene panels, both for genetic thrombocytopenias and looking at the immune system that are readily available. And I know too that Dr. Cooper has a research study too where she's looking at this question specifically in individuals with ITP here. So if people are local to her area, then that's a possibility as well.
I mean, in theory, you can get a second opinion. In practice, it's increasingly possible. I think medics are less paranoid these days about being questioned. I'm certainly in the past, I know exactly what I'm talking about. I don't possibly need a second opinion. And if you want to go and see someone else, don't come back and see me. That was a common attitude 20, 30 years ago. But I think the point Ella made, it's imbuing curiosity in the clinician. Ask them questions to make them think about it rather than just dismiss you. And that's, again, one of the reasons why a clinical nurse specialist is important, because a clinical nurse specialist can glean information out of you about your problems that the doctor may not, because he's trying to hurry you through. I think it's an important point.
May I just add quickly to that? I just think thank you, Dr. Grace, thank you, because I just think as a patient in the British system at least, it is a bit of a lottery ticket of who you see, and I'm so fortunate that I have a consultant that is really curious as to why and asks those questions, but I think and worry for maybe smaller hospitals without a specialist ITP carer that those conversations aren't had. So maybe it's something for the haematology community to have a think about how to disseminate that information and get all haematologists to have those conversations with patients.
It's one of the things we've tried to promulgate with the ITP Clinical Forum. So you have 18, 20 hospitals with someone who has a specific interest in ITP, with a sort of network of the smaller hospitals around them who can refer in. Some haematologists, and it's mainly haematologists now, are quite happy to have that networking that helps them. Some aren't. It's increasingly, the some aren't are increasingly reducing, but they're still there, I have to say. I think, Nikki, did you want to make a quick point? Because we ought to move on.
Yeah, thanks. So thanks, Rachel, just talking about, there is a research study called the NIHR Bioresources that is aimed at looking for genetic causes for ITP, and I've talked to Mervyn a bit about this, and so you can contact the Support Association and we'll sort of put together something together to see if you're eligible for it, and how we can kind of facilitate that happening for you, because it's a lot of paperwork and a lot of places won't be set up to open that, but as a research group, Imperial will try and facilitate that. So Mervyn, we can talk about that a bit more.
But I think the point you made was an important one about getting the diagnosis right, because, and then we'll explore it a little bit in the Q&A, and I think we've all had patients referred to us in their adolescence with so-called refractory ITP and recurrent infections, and no one's ever looked to see if there's an underlying immune deficiency, and the treatment they've been given for ITP has just made their infection risk worse, and I think that is important, and we'll perhaps explore that a little bit in the Q&A. Fine, thank you. We'll move on now. Thank you very much, Rachel. We're going to finish off the formal presentations now with one that we all get frequently asked by patients, and it's a question we can never answer, so Jecko's going to answer this for us. Why do patients go up and platelets go up and down? It was discussed this morning about the patient who's completely stable, nice platelet count, and suddenly they go and have a blood test and the platelet count's less than 10. Nothing else has happened, and Jecko's going to tell us. Thank you.
Thanks, Professor Newland. It's been about 25 years when I first went to my ITP Support Association meeting, and it's always in a very posh place, I have to say, so I like going for that reason alone. But the main reason is I learned from all of you. So I'm going to start, because when we do these presentations in big meetings, we're supposed to put a disclosure slide. And I have to say, my disclosure slide says, I have learned most of what I know in ITP and many other diseases from my patients, number one. And secondly, there are some people who look very young, although in the front especially. They are very clever. I think their brain is wired differently. And of course, nurses, because I remember when I was a young doctor, my specialist nurse, she's called Rose Fools, she told me, you will go far if you listen to nurses. And I tell this to all my junior doctors because it's most important. So my sincere thanks to all of you for all that you've taught me and taught all of us. You've seen from Dr. Grace these platelets. These are big platelets, but I just want to tell you platelets and why I got interested in platelets about 20 years ago. It's mainly because platelets are purple and my wife's favorite color is purple. And we all know the Platelet Support Association, especially the PDSA, use the word purple, and it's because when you look under the microscope, when you stain the platelets, it looks purple. But I also have some interest in art, not as much as Professor Prowan. I know you're an expert at this, but art is amazing. So I looked at why we call it purpura, and of course it's just, we just had our new Pope, and this is from Sistine Chapel, and Jesus has a purple robe. He may not look very purple. The older purple is slightly different to the ones we have. And the word purpura comes from purplish, because the purple color was made by, actually this is from a gentleman called Peter Paul Rubens, who actually painted this, and it was picked up because the dog is bitten a seashell, and a purple dye comes out of it. So it's in a place called Tyre, which is in Lebanon now. In those days, you had to kill, unfortunately, 25,000 of those shells to make 1 gram of purple, which is why if you look at paintings, most of the paintings have purple only on the most important figures, Jesus or a king. So it's called royal purple, and of course platelets are the most important blood cells. Yeah, a bit biased, isn't it? So it's purple. Platelets were not known until 1880s. It was called a dust. Platelets were called blood dust. It wasn't called platelets. So, to look at how platelets are born, I'm just going to show this. You know Anne Geddes? Anne Geddes, beautiful photograph she makes. So platelets comes from this big cell called a megakaryocyte. It's called big cells, so it's mega. And you can see it's quite big, isn't it? And one of the other things which is in there is it's got lots of things which clump together. It's the nucleus, it's a mega nucleus as well. And it was discovered by this young man, he was 34, this is when he was 20, Giulio Bizzozero, Italian handsome man. And actually, he drew that picture, and that's actually his depiction of platelets inside a blood clot. And I have to say, even now, that's exactly right, because we would know a lot more in the last 100 years about how platelets work, and that's exactly right. So he used to call, he named it as piastrin, which is Italian for small plates. Now, I don't know why. Does it look like a plate? Maybe. Doctors usually like apples, pears. If you look at medical books, we say apple-shaped, pear-shaped, and I don't know, we probably like our food a lot, so we use these things. So he anyway chose plates. It used to be called in German, because German was the main medical books were written in German. So Blutplacken, which is so petit plaque in French. And what is fascinating is he picked this up by using that microscope. Nowadays, you need a room for a microscope because it's that big. We do have smaller ones, but this is what he used. That's just unimaginable, amazing. How is platelets formed? So you have this big megakaryocyte. You can see it's very big. And one of the important things which I need you to remember, you can see those small dots. They're called the granules. These are probably the most important thing inside platelets. And the first thing it does, actually, to make platelets, it actually starts putting hands out. Because we like friends, isn't it? We like to hold hands, although these days not hold hands, but at least in many countries we still hold hands to be friends. So you start putting the hands out, and you call it pseudopod. And the pseudopod will start elongating. It goes stretch, stretch, stretch. So the big one gets smaller. And then what happens is it sees a blood vessel, and it'll put the hand inside the blood vessel. Because the blood is flowing fast, it breaks off. Now, in one day, it happens about 1 billion times. For me, it's absolutely amazing. Sometimes my wife is worried I'm having an affair with platelets, because I just think it's just unimaginable what this process is happening every single day. And one of the other things I am not going to do, my colleague Dr. Granger is very good at dancing, is those granules will actually wiggle. I'm not going to do the dance, but wiggle into the tips. So the granules from the megakaryocytes will reach each platelet. And it's called platelet granules. So that's how its platelets are formed. We don't know where it exactly is formed. People say it's found in the bone marrow, but there's some confusion that it could be made in the lungs. So anyway, that's a bit controversial. So I'm going to ask you a question, but I'll give the answer just to make it quicker. What's the function of platelets? So according to AI, which is what we all follow anyway, it helps in blood clotting. Yeah, this is AI, so this is new. This is all the information put together. So it's called blood clotting. But is that true? So this is my own cartoon I use to teach people how bleeding stops. So what I have done here is that you can see the yellow thing is your blood vessel. It could be your artery or vein or something called capillary. Under the blood vessel is something called collagen. Collagen actually gives the strength to the blood vessel. And that thing which is red is called the 1 Willebrand factor, named after a particular man called 1 Willebrand. He's a Swedish guy. What first happens, this is something which most doctors forget. When you have an injury, usually caused in a hospital by a surgeon, I hope you don't have any big friends with them, but I'm sorry if you are, is the blood vessel will constrict. Okay, it makes perfect sense, because if you have a hole in your blood vessel, it'll constrict to close the hole. Very easy. If it is a small hole, that's what happens. If it's a big hole, that will not happen. And the surgeons ring me, their favorite time to ring me is 3 in the morning. I don't know why, and say that I have just done the surgery and still bleeding, but you haven't stitched the gap. You continue to bleed. So that's the first thing. The second thing which happens is purple platelets. And the platelets put these hands out and hold each other. And technically, we call it platelet aggregation, and you could call it platelet plumb or platelet plug. It's a bit like if you have a sink, you have that black thing which you put in the sink to stop the water flowing out. So it's a plug. But the important thing is, I know Professor Newland has got a Bentley, his car goes very fast. So the car goes very fast because the platelets in the blood circulation goes extremely fast. And it has to stop here. There's no point stopping there or there. And how it stops there is this 1 Willebrand factor will put his hand out. So where I come from, we have a lot of elephants. And the elephants, you might have seen in Attenborough's videos, it does that. And that's what exactly it does. This was only figured out 10 years ago. But David Lane, who works near Professor Cooper, so it puts the hands out and catches the platelets. So the platelets stop there, and it gets activated and forms a plug. Isn't that fascinating? You don't think so? Okay. For me, it is. And then it forms something called blood clotting, which is the least important. Now, why did I say this to you? Is because, why does platelet count sometimes go up? Because when someone starts bleeding, the body senses that we need more platelets to stop you bleeding. Yeah? And for that, again, there's an amazing mechanism. This is quite, again, for me, is quite exciting. There's a bit, this is called stem cells. You've heard stem cells many times. But when it divides into something called white cells and red cells and platelets. But the one which is quite amazing is called MEP. And that stands for megakaryocyte erythroid progenitor cell, because that creates red blood cells and platelets. It doesn't help with white blood cells, because when the red blood cells are lost when you're bleeding, the platelets go up. So it's the mechanism already done by the supreme power, as you call it. There's a connection between these two, which is why the commonest cause of platelet count going up, not just in ITP, but in general, is bleeding. After operations, when the person is bleeding, and when they're anemic, because it's usually caused by bleeding. Now, something I have to say, I have been thinking for quite some time. I have some of my patients here, shouldn't say where, but it's in the audience, is the relevance of menstrual bleeding and platelet count. There's been an interesting webinar in the last month about ITP and menstrual bleeding. Now, I personally think there is a link between menstrual bleeding and the platelet counts. Is it proportional that it goes up, or the opposite goes down? Is it because of the bleeding, or is it because of hormonal? We don't know. But I am absolutely certain, and some of my patients know that I do ask when the platelet count dips when they come, was related to menstrual bleeding. Anyway, I don't have an answer, but it's just a thought. And the second thing which happens with the platelet count going up is here, what I've tried to show here, somebody's got an inflammation, so they have, say, arthritis. So itis means inflammation, so arthritis, tonsillitis, appendicitis, all the itis. And what happens when you have itis is the white blood cells, which I've shown in pink. One of my friends likes pink. It's called eosinophil. Eos is a god of Easter, so it's pink in color, and the lymphocyte is blue. So it actually is attracted by platelets, interestingly. So we thought that platelets help in bleeding, stopping bleeding, but also attracts white blood cells to come to the site of inflammation. So when someone's got itis, whatever itis it is, the platelet count will go up because it's helping in dealing with that. So this is another important reason for the platelets to go up. And how it does is with these granules again. It releases the granules, we call it chemokines, and these granules will attract the white cells and bring it to a site of inflammation. So, is the function of platelets to stop bleeding? Yes, it is. But there are 330 granules inside platelets. There's an awful lot more it is doing than stopping bleeding. And do we, doctors, know about it? No. Despite figuring out there's about 330 different types of granules. In general, it's about 4, but we say inside the platelet all these granules. So, which brings me to, you've heard from Dr. Grace about the relevance of infection in causing triggering ITP. So let's look at how that happens. So this is, of course, how platelets might help us in fighting infection. And one thing it does, there are things inside those granules which is antibiotic. It fights infection, which is why the platelet count will go up when you have an infection, because it releases these granules, it functions as antibiotic. And the other thing is that they can directly attack. When I was doing my research, please don't judge me, I took bits from teeth, plaque. Okay, only people who have got bad teeth, so it doesn't apply to any of you. And you put it in platelets, and it will activate the platelets. Bad news, if you've got bad teeth, you're likely to have platelet problem. It's not a joke, it's true. It's been shown that there is a link between poor dental hygiene and heart disease. And the other thing, what the viruses or the bacteria does is, it doesn't want you to kill them. So what the viruses or bacteria does is that it goes inside platelets. When it goes inside platelets, your body's immune system can't detect it. But however, when the platelets have the viruses inside, it will start forming some antibodies to it, because it's a bit unusual. So when it goes past the spleen notices your platelets don't look normal. So it does what is called culling. Culling, as you probably heard from the time of, I don't know about BSc, it was a long time ago, but the animals get culled. So that is one reason for ITP. In ITP, the platelets get culled because of these antibodies. So what is the relevance of platelet and infection to ITP? Infections are a common cause of thrombocytopenia, especially in children. It's quite common. So in most of these cases, just by treating infection, the platelet count can go up. However, in the patients I treat in the adult setting, sometimes the patient's platelet count can go down if they have an infection or inflammation, and sometimes it can go up. So it's important, if someone's platelet count is normalized suddenly, you don't discharge, your doctor don't discharge you, because you need to make sure that if you had an intercurrent infection or inflammation at the time, it might go down again. And if someone's got stable platelet count and suddenly they drop the platelet count, it is likely to be due to an infection or inflammation, and at that time you only need a short course of therapy. The problem what I see is that many doctors tend to say that the treatments don't work and they change, and this will cause problems. And I have seen this, and it could be due to what is called the regulatory T cells being put back in. Sometimes an infection can precede ITP remission. I do get asked a question very often about platelet count fluctuations for TPO. This can be very common, and this is a possible explanation. So on the megakaryocyte, the big cells, you have TPO receptors, and the platelets also have TPO receptors. So when you give injection or tablet of a TPO, the amount of TPO goes up, and it produces platelets. However, when you have lots of platelets produced, depending on the response, the TPO receptors on top of the platelets mop up all the TPO you're giving, and then the megakaryocytes doesn't have enough platelets to produce more platelets. So what tends to happen, you see this yo-yo happening. And again, I have seen some clinicians stop the treatment because the TPO is not working. That is wrong. If the patient is not bleeding, sometimes we tend to switch the TPO, or we can add in prednisolone or MMF or other drugs which can actually stabilize the platelet count. So, is ITP all down to infection and inflammation? One of the best slides from a clinical point of view in ITP. This is from Doug Sines and group. So this one shows who are the patients with ITP who will remit, who will go into remission fairly quickly, and who are the ones who don't. If it's a trigger like some infections like cytomegalovirus, so there are different viruses there, it's a transient trigger and the ITP can go away. On the other hand, if the trigger, like autoimmune condition or SLE, Evans syndrome, antiphospholipid syndrome, and you've heard from Dr. Grace about immunodeficiency, it is unlikely that the ITP will go away. So it's important for clinicians to know what is the trigger for ITP and treat the trigger as much as possible. It also tells us which person is going to have acute or chronic ITP. Towards the last part, I'll just talk about autoimmune disease. So this used to be when I started doing medicine, ITP was idiopathic thrombocytic purpura, and then we have all the wonderful people sat in the front, come up with this consensus report, which I still use, the 2010 one, because it's got a nice table on page 6 of it. I still use it, and yes, of course, I use the 2019 selectively as well. I would not dwell too much on this, but does all of you know about what happened with this? Yeah, you do. So. Yes, okay. So what does platelets do? So this is an activated platelet. Platelets also work as immune cells. So it fights an infection. It also participates in autoimmunity, which is why there's a problem with an autoimmune disease. The commonest blood line which is affected is platelets. And this is from Dr. Cooper's wonderful New England Journal of Medicine review paper of the mechanisms of, again, you can see how platelets and megakaryocytes interacts with different blood cells. Now, this is a bit more recent. What I wanted to show you here is that there is multiple mechanisms by which ITP develops. So, if the same treatment is given for everybody, it may not work. So we need to think as clinicians that ITP is not a single disease. It could be multiple things happening, so we need to select. Do we know all about it? Maybe with all the work which is being done, we will in the near future. So this is my summary for ITP. As far as I know, on the right of me is situations where there is a well-known trigger, an infection, inflammation, and molecular mimicry is when actually the viruses and things go inside the platelets. In such cases, if you treat the underlying infection or inflammation, it will get better, and it'll stop at the stage of newly diagnosed or persistent. They go into remission. This is why, like Dr. Gray said, it's extremely important to look for an underlying cause, because if we deal with that, ITP will not become chronic. On the other hand, if there's loss of immune tolerance, I didn't go into detail about how it is, but it's what's called an imbalance between the regulatory T cells and the cytotoxic T cells, genetic predisposition, Dr. Cooper is looking at it, and an altered immune state which is different to T cells like complement. In such cases, you cannot get rid of it. So it is likely that ITP is going to become chronic. And I think we need a lot more research on this side because we still don't know how to pinpoint where the problem is. How much is the genetic predisposition causing the ITP? How much of the imbalance can we reset the imbalance and all that? And this is my final slide before saying thank you. This is a question to all of you. I've created this slide because at the bottom we have a platelet count less than 20. Okay, and generally people think a patient might bleed and it's less than 20. But not all patients. Not all patients with platelet count less than 20 bleed. So there must be, and I believe in this thing called yin and yang. It's a Chinese concept, but basically a balance. We all have a balance. There are a lot of other things coming in there, and we only look at the number of platelet. So I think we need to know a lot more about all these other factors which can determine the bleeding risk. And we need to measure them so that we can say, well, this patient does not require any treatment despite the platelet count of 10 or 5, or this patient does need treatment with platelet count of 20. Then we have these magic numbers, and I'll tell you something which please don't get upset. People say we should use a platelet count of 50,000 for surgery. This is based on zero evidence. Absolutely nothing. And then for neurosurgery, we should use, because they're more important people, brain surgeons, we use a platelet count of 100,000. No evidence. So I don't know why we still use these numbers, because this just doesn't make sense. And sometimes it can be difficult. There will be patients who's got platelet count of 30 with no bleeding, suddenly goes for tooth extraction. And then once a dentist, he's a nice man, he told me, I need a platelet count of 60, not 50. So I said, where does 60 come from? Oh, that's what I've always done. You can't say things like that. You can't just say that's what I've always done. So we need to have more evidence for this. So again, we could measure something called overall clot potential. Again, it's a research tool. Now, I've told you that platelet count goes up in infection and inflammation. So when a patient with ITP has got platelet count of 50 going fine, and if the platelet count doesn't go down, and if I have a bacterial infection, they've just been to Thailand and just come back and have got bacterial infection. Should we aim for higher platelet count? I don't know. But you would think if a person without ITP platelet count goes up, what about a person with ITP? So these are questions I don't know. And lastly, why is a platelet count a normal 150 to 400? When we all know the platelet, nobody will bleed with a platelet count about 20. I think it's because it does an awful lot of things, because there's 340 granules in there. But what are these things it's doing? We don't know, but we need to know, because it's been known for quite some time, a lot of granules. Now finish off, this is Manchester. I have to say, you're all lucky you don't see this weather in Manchester. It's probably people who say, you brought the sun. This is the first time in the last, I don't know, many years I've seen such a wonderful weather. And it says, concilio et labore, which means we need to work together, city spirit of collaboration and hard work. Thank you.
Thank you, Jecko. We won't take a question now because we just have about 15 minutes at most for a few questions. So we have 4 seats, which anyone who wants to come up and answer a question can. Anyone else who wants to come up will have to bring a seat. And I wouldn't ask everybody up just because it'll take us 15 minutes to get up here. But perhaps we could just pose a few questions and people could answer them where they're sitting. Do you want to have a seat, Jecko? You're attractive. You're an attractive young man. They'd like to look at you. A question. I'll just pose a question while people are thinking, and I think we've heard a lot of talks today, and I think Rachael highlighted it about the issue of diagnosis and not getting it wrong because the treatment can cause problems. How much should we try and diagnose people at presentation. I mean, the guidelines have long lists of things that we should do. You know, that's in the words of non-Americans will understand, Tony Hancock, that's an armful to do all those diagnostic tests. How many of these tests should we do at presentation? Should we always do immunoglobulins? Should we always do clotting tests? Should we always do a ream of autoantibodies? Personally, I think we should, but I'm just interested in others' opinion, whether you do some to make your diagnosis. David, you just nodded your head. There's
Well, again, I think it depends upon, the pediatricians differ from the adults because adults rarely see inherited disease late in stage. So I will simply say that we miss it occasionally, but much less than you think we do. I think in terms of a generalized ITP patient, if someone comes with ITP, I'll check an autoimmune panel, which is anti-thyroid antibody test. I'll check an ANA, looking for lupus. I'll check an immunoglobulin, a serum protein electrophoresis. I will obviously look at the blood smear. I often check for antiphospholipid antibodies to make sure they don't have secondary disease there. And I will occasionally do flow cytometry to see if they have a clonal B-cell disorder. But I don't do bone marrow, so I don't do a lot of other tests, and I don't order genetics tests unless there's a family history of my mother had it, my sisters got it, and my kids all have it. So I think right now we may miss such patients, but the key test in adults, I think, is whether they have a good steroid response, and most people still get steroids, so I think I use that as the arbiter of whether someone really has ITP. If they don't have immune response in terms of steroid response, I tend to worry about other things going on.
And it's also very disappointing to get patients for a second opinion who haven't responded, who received intravenous immunoglobulin and haven't had their immunoglobulins checked. And I think that's a complete nightmare. Okay, another quick question, unless I say, wave a hand if ever you want to ask me. The other question I was going to ask was, again, we saw from Fred how treatments changed, and he posed the question, which I thought was an interesting one. Are we now under-treating with immune suppressants? And we saw the trial that Charlotte Bradbury did, adding mycophenolate initially with good responses. We're now using a lot of thrombopoietins. Should we be looking at a thrombopoietin plus an immune suppressive at early presentation to try and enhance responses and reduce later problems, which I think the registry is beginning to show is the case if you get a response early. Patients treated early respond well. If they respond well early, they need less treatment later and their problems are less. Should we be looking more at multiple therapies? At cost, of course. Charlotte. Catherine. I'm not Catherine. Please do. I've been embarrassed to call you Charlotte.
I was going to say, hopefully, the RODEX study will give us some idea about that, where it's dexamethasone or dexamethasone plus romiplostim given up front. And that could hopefully show us the way. Yeah. I think we do now have a tendency to avoid immunosuppression, though. I think the pandemic has put us off it.
Yes.
But by stimulating the bone marrow with a tuphomimetic only, are you missing a trick with using a bit of immunosuppression on the side? Should we be using slightly less TPA with a bit of immunosuppression? Difficult to know. But the RODEX result might be the first answer to that, possibly.
I mean, it was about the only good thing that came out of COVID, wasn't it? The reduction in using too much steroid at presentation. It didn't sort out Boris Johnson properly, but it did a good thing with the immune suppression. Does anyone, Ella?
I have a bit of a controversial question, I think. Just around splenectomies, that's a treatment that I had and didn't work, and what the view is on splenectomies now. Are they used at all? Are they used in worst case scenarios? That's my question. Thank you.
I mean, I have a semi-controversial view, and I'm sure David Cooter would disagree with me. I think you shouldn't have a spleen taken out unless you have a splenic survival test. Of course, they're done very few and far between now. We used to do a lot at the London, but as the number of splenectomies dropped off, the number of tests were done. And we did develop a series of centres around the country where you could have it done. But I mean, my personal rule of thumb is if you fail lots of treatment, you aren't going to respond to a splenectomy. Should anyone take a spleen out?
As I said yesterday, literally, I think it's a rare patient who needs a splenectomy. I don't do it personally. And I'll be honest, I lied yesterday at a different conference saying I never did it. I've done it twice. These are Air Force pilots who want to get back to their carriers within the next 2 months. And so both Air Force pilots had their spleen taken out. One died, the other is back in the Air Force, in the carrier. But I rarely do this because I think we have medical therapies that are so good right now. And I'll also say that if we had this meeting in France, we'd be talking a lot more about Rituxan because it's cheap, it works pretty well, and I think that we should not take it off our list despite our history of avoiding it during COVID.
I mean, the old rule of thumb was that if you responded well to steroids or intravenous immunoglobulin, but the response was transient, you had a much better response to splenectomy. But of course, that was decided pre-TPOs. So I think that's...
Yeah, so
Nikki.
it's a very difficult question actually, because I think for some people I've taken 2 spleens out, I think, and both were successful. And for one, it was in a 12-year-old boy, and he went into a complete remission, and now has the better quality of life than any of our other children with ITP. So I think the hard thing we have is we don't have that good predictor of outcome, actually. And I think for some people who've had their spleen out, they have better responses to rituximab to last for 2 or 3 years rather than 1 year. And actually, I think that's a better quality of life for some of those patients as well. So I think that it can create a better quality of life. I think it's just a hard decision to make.
I mean, that's an interesting point, actually, because many people would question taking a spleen out of a 12-year-old. And it may be a better quality of life, but once your spleen's gone, your spleen's gone. Yeah, no, it's difficult. There is not an easy answer to that.
I doubt any of us would hold you in contempt for this, but it's also simply raised the question that when you take a spleen out, you create a new disease, which is asplenia. And unless you are very assiduous about having your vaccinations, if you see one patient with overwhelming pneumococcal sepsis or other overwhelming sepsis and see the digits fall off in the ICU, you very rarely want to do this. It's a catastrophic system, an infection which rarely occurs, but when it occurs, it's bad. And this is why the Australians got a thing called the Spleen Society. I don't know if you're aware of this, but everyone who's had their spleen taken in Australia is part of a registry. And you get an email every 5 years saying, get your vaccinations, and here's a kit of antibiotics to take if you have a temperature over 101. And it's because they've had a very large concern in their patients who have spleens out for many reasons to avoid infection. I should also say that the hazard ratio for thrombosis is 2.5-fold higher if you have your spleen taken out. There's an increased risk of cancer, which is 1.8-fold higher. There's a lot of long-term issues with splenectomy, increased cardiac disease long-term. So if you got to counsel a patient about all the long-term risks of splenectomy before you do it.
I mean, I think that's something that people forget, and this was shown from the old Framingham studies from the American forces. The increased incidence of cardiovascular disease long-term after troops had a traumatic splenectomy. We've discussed today quite a bit of unmet need. We started off with a talk on unmet need. I can see at least 3 people around the table at the front who are co-authors on a patient on a paper in the Journal of Pediatric Blood Cancer on pediatric immune thrombocytopenia addressing unmet needs. What unmet needs? I mean, the case in point that Nikki's just raised, I think, highlights that, and Rachael's presentation does too. There are significant. We haven't really addressed pediatrics much today because there aren't a lot of peds here, unfortunately. But there are significant pediatric unmet needs that we tend to gloss over because the majority respond so well. How should we be stimulating more work in that? Unless there's anything pressing, this is the last question.
Well, I guess I would disagree with you that there isn't work being done on this. I think it's not being represented, I guess, at this meeting today.
Being provocative.
So that seems controversial to me. So I think many of us spend a lot of time working on that, and there's in North America a large group of investigators who work on pediatrics and pediatric immune cytopenias, and that article does outline a lot of the unmet needs that are overlapping really with the adult population, that we do have many children who don't respond well to treatments, who we want to understand the underlying issues better, that we have the impact on quality of life and addressing fatigue and impact on school and activities, and then needing more treatments, which many of the treatments are studied in adults with ITP and not in pediatrics, and so we don't have as many treatments as the adult
You
patients.
highlighted a myriad of really fascinating conditions that are much more appropriate to pediatrics than adults, that really often aren't thought about, with treatments that we don't even consider, which I think are really very important.
Yeah, I think identifying sort of that target, right? Is there a targeted pathway? Maybe in children even, we're seeing, we are really concerned about those underlying primary immune deficiencies, or those underlying, the missed hereditary thrombocytopenia that's getting missed or overlooked.
Yeah.
But I do, when we were working on, just to kind of loop in a little bit of our terminology and discussing differences in adults and children, one of the things that we were really trying to think about was enrollment in clinical trials. And it's always an age-based cutoff, which is rather arbitrary. And we don't even really know the age at which a child is expected to act like an adult with their ITP. And so really, one thing is consideration for almost weight-based enrollment. If you're a particular weight and we think that you would, that would really open up clinical trials to more and more children, rather than saying, oh, you have to be 15, which is rather arbitrary, so.
Yeah. Nikki, I think you want to make a point. And then David, and then that's it.
And then one final point is actually something Ella brought out was actually transition is terrible, because actually there are not very many teenagers with ITP. We're not doing a good job of making sure once they get to 18, they go into another service. And Ella, you were saying that you had ITP suddenly as at university, and then you're immediately into an adult provider, not someone you know or you've ever seen before, and it's a very different place. So
are there others in the audience who presented as an early teens or peds who are now into adulthood? Yes, so a number. Yeah. Did you have problems? Did you find it difficult moving from a pediatric follow-up to an adult follow-up? Yes.
7,
Yeah.
which I always think, I've been speaking to a few doctors, which I always thought, why was this done? But that was the time when my parents took a call and they said it was life-threatening for me. So we didn't think about the consequences. But now, being in this conference, being in the day, I think, people here today have got so much more opportunities, all the new treatments, all the new drugs that have come up. Please do not do splenectomy. If possible, avoid.
Yeah. Okay. David, you wanted to make a final point or a question?
I had a comment about a topic we haven't talked about, which is pregnancy and ITP, or ITP and pregnancy, which is a big, open, unmet medical need that we don't have a good solution for. These are patients who, for me, are the most difficult to take care of.
That's an interesting point, and I think that's a good point to finish on, because I'd like to say that the Patient Support Association is currently developing a document on pregnancy and ITP that's along the lines of our shared care document. This is going to be a shared care document on pregnancy and ITP, that we've got a really good group to look at that, with people who are interested in the BSH in neonates from pregnant women, is going to incorporate some of the data in our shared care document, because 50% of women present with ITP in pregnancy, or low platelets, it's probably ITP in pregnancy. So we want to be able to handle that as well, and that'll have input from the pregnancy registry as well. So I think this time next year we'll have that document, and hopefully we'll have some sort of presentation on it as well. So, final point.
Final point?
This is the third final point.
I was just going to say, we had a really good discussion in the women's small group, and I think the other sort of area that is really untouched upon is really having good discussions about heavy menstrual bleeding in women, and women's health surrounding ITP beyond pregnancy, just in the care of adolescent girls and young women and women. And then we had lots of discussion even around hormonal replacement therapy. And so I think there are a lot of very women's health specific issues within ITP that came about that we could really expand on.
And that's something we need to think about. Okay. Now, I'd like to finish now by, I'd like to thank the staff for Bridgewater. I think this has been a fantastic venue, and the staff have looked after us really well today, and a nice lunch. I'd like to thank Mervyn for all his organisation and the speakers, but I'd particularly like to thank all the people who've come, the patients and their carers, and their supporters for what's been a really fabulous day and a discussion. And I'm terribly sorry to break it off so quickly, but we do have to finish by 5. Thank you very much, everybody.